Infants lose heat through four mechanisms, those being evaporation, conduction, radiation, and convection. Hypothermia is associated with increased morbidity and mortality. The infant's temperature on admission is inversely related to mortality and sepsis. For every 1 degree Celsius an infant's temperature drops below normal on admission will increase the rate of mortality by 28% and the incidence of late-onset sepsis increases by 11%. Thermogenesis maintains a balance between heat production and heat loss. Infants respond to hypothermia by preventing heat loss through voluntary muscle activity, involuntary muscle activity, and metabolism. An early response to heat loss includes increasing voluntary muscle activity during restlessness and crying to generate heat, but this process is limited and requires large stores of energy. Term infants may assume a flexed position to prevent heat loss by reducing exposed surface area. However, this process is limited in preterm infants. Another mechanism to minimize heat loss is through peripheral vasoconstriction, where the blood vessels in the arms and legs constrict. This reduces blood flow to the extremities and decreases heat loss through skin surfaces. Shivering thermogenesis is a response to cold exposure where heat is generated through skeletal muscle activity. However, infants lack sufficiently developed skeletal muscle mass to maintain body temperature through shivering thermogenesis. Most infants usually don't develop the ability to shiver until about 6 months. However, some infants may shiver but only when their temperature is extremely low and other heat-generating processes have been exhausted. The primary method of thermogenesis in infants is non-shivering thermogenesis. Non-shivering thermogenesis produces heat mainly through the metabolism of brown fat. Brown adipose tissue is a specialized fat cell that is innervated by the sympathetic nervous system and contains an abundance of mitochondria that are highly efficient at generating heat. This is different than white fat found in adults, which has low density of mitochondria and is primarily used for energy storage. Brown fat deposits are highly vascularized, which facilitates the exchange of oxygen and glucose to generate heat. Production of brown fat begins around 26 to 28 weeks gestation and continues until 3 to 5 weeks after birth. At term, brown fat accounts for about 2 to 6% of the neonate's total weight. Infants less than 32 weeks gestation do not have enough brown fat to produce heat by non-shivering thermogenesis. Brown fat is located primarily around the back of the neck, in the axillae, between the scapulae, along the abdominal aorta, and around the kidneys, adrenals, and sternum. When heat loss is greater than the infant's ability to conserve and produce heat, the infant becomes cold-stressed. This begins a process in the sympathetic nervous system triggering the release of norepinephrine, which causes numerous effects on the infant. First, norepinephrine causes peripheral vasoconstriction which reduces blood flow to the extremities and focuses maintaining heat at the core. This causes the infant to develop acrocyanosis. If untreated, it affects tissue perfusion leading to hypoxia and acidosis, which causes pulmonary vasoconstriction. Norepinephrine alone also causes pulmonary vasoconstriction. It is also important to note that hypoxia, acidosis, and hypothermia all impair the production or secretion of surfactant. This pulmonary vasoconstriction causes an elevated pulmonary artery pressure which leads to right-to-left shunting through the foramen ovale and ductus arteriosus leading to some degree of pulmonary hypertension. The combination of acidosis, hypoxia, pulmonary vasoconstriction, and impaired surfactant all lead to the infant developing various respiratory symptoms. Norepinephrine alone also causes pulmonary vasoconstriction. It is also important to note that hypoxia, acidosis, and hypothermia all impair the production or secretion of surfactant. This pulmonary vasoconstriction causes an elevated pulmonary artery pressure which leads to right-to-left shunting through the foramen ovale and ductus arteriosus leading to some degree of pulmonary hypertension. The combination of acidosis, hypoxia, pulmonary vasoconstriction, and impaired surfactant all lead to the infant developing various respiratory symptoms. Norepinephrine also acts to increase sympathetic activity to increase metabolic rate and acts on the beta receptors inside brown fat cells to stimulate non-shivering thermogenesis. The large number of mitochondria inside the brown fat cells begin to generate high amounts of heat through the consumption of large amounts of oxygen and glucose. This increases the risk for the infant to develop hypoxia and hypoglycemia. The breakdown of brown fat also releases non-esterified fatty acids, or free fatty acids, which bind to albumin competing with bilirubin for binding sites, which places the infant at risk for developing hyperbilirubinemia. Neonatal cold injury is a rare, severe form of hypothermia that occurs in infants of low birth weight or term infants with central nervous system disorders. It is more likely to occur with home deliveries, emergency deliveries, and deliveries in low-resource settings. The infant with cold injury will present with redness of the hands, face, and feet with a pale central body. There may also be edema in the hands and feet. This severe hypothermia causes multiple system disturbances that lead to severe hypoxia, circulatory collapse, hepatic and renal failure, and inappropriate activation of the coagulation cascade, which may lead to disseminated intravascular coagulation and pulmonary hemorrhage. The hypothermic infant may exhibit a variety of symptoms. Because of the vasoconstriction, the infant may appear with pale unmottled skin, acrocyanosis, and even central cyanosis. The infant may develop symptoms of respiratory distress such as tachypnea, retractions, nasal flaring, or decreased blood oxygen levels. If the infant develops hypoxia or hypoglycemia, there may be apnea, bradycardia, lethargy, poor muscle tone, and weak cry and suck with poor feeding by mouth. Hypothermic infants will consume large amounts of glucose and oxygen while trying to raise their body temperature. It is important to monitor these body systems by checking blood glucose levels and monitoring blood oxygen levels frequently. If the infant's glucose is low, feeds should be started or given, or intravenous glucose should be initiated along with frequent monitoring of blood glucose levels. The respiratory system should be supported to provide at the level needed. This could include supplemental oxygen alone, or oxygen with positive pressure along with continuous blood oxygen monitoring. Rewarming is the main intervention to mitigate hypothermia. However, the speed of rewarming remains controversial. Proponents of rapid rewarming believe it may lower the risks associated with prolonged hypothermia, while proponents of slow rewarming believe it may have a protective role on cerebral blood flow and rapid cardiovascular changes. Current literature has found that the rate of rewarming was not associated with the incidence of hypoglycemia, late-onset sepsis, respiratory distress, length of stay, or mortality. However, rapid rewarming was associated with higher rates of the infant becoming hyperthermic. Best practices should include rewarming at a rate of 0.5 to 1 degrees Celsius an hour until normal body temperature, while closely monitoring vital signs every 15 to 30 minutes to prevent overwarming. The infant is at high risk for developing hypothermia in the minutes immediately after delivery. Interventions in the delivery room are aimed at maintaining the infant's temperature between 36.6 and 37.5 degrees Celsius. The delivery room temperature should be at least 25 degrees Celsius for all infant births. After delivery, the infant should be immediately dried to prevent evaporative heat loss or placed skin to skin with the mother and dried. A hat should be placed on all infants to minimize heat loss. If resuscitation is anticipated, the radiating warmer table should be pre-warmed for 15 to 20 minutes before needed, if possible. Infants under 28 weeks gestation or 1,500 grams require special considerations including room temperature at least 26 degrees Celsius or 78.8 degrees Fahrenheit for any infants born at less than 28 weeks gestation. Utilize a chemical warming mattress. Instead of drying immediately, these infants are immediately placed, wet into a polyurethane or polyethylene wrap or bag to conserve heat. If any respiratory gases are needed for resuscitation, they should be warmed and humidified to prevent evaporative heat losses. Resuscitation should be anticipated, so the radiating warmer table should be pre-warmed before needed. After resuscitation, the infant should be transported to the intensive care unit in a heated transport incubator, wrapped in a single or double-layer blanket as required, and with a hat on. Hypothermia during procedures can have serious implications and may lead to the damage of various organs. Lower gestational age is directly correlated with the main risk for the development of hypothermia during a procedure. An overhead radiant warmer and thermal mattress should be utilized as appropriate. If an infant is under drapes, the drapes will block much of the heat from the radiant warmer and an extra thermal mattress may be needed. Hats should be placed on all infants at risk for heat loss. If the infant is in a single room, the ambient temperature should be increased to 78.8 degrees Fahrenheit. There also should not be frequent opening of the doors while the isolette is open. The infant's temperature should be continuously monitored during the procedure, and interventions are made as appropriate to address hypothermia or hyperthermia.